The preview is presented by Monica Ockrey. Monica was shaped at an early age by denial of healthcare services of her special needs sister. She's collected more data about improving healthcare throughout her life and her studies in molecular genetics.
Hi, I'm Monica with Health Care for All Minnesota. In 2023, the Minnesota legislature passed a bill requiring the Minnesota Department of Health and Human Services, DHS, to publish several studies that address the high cost of healthcare. Concern about the high cost of healthcare is what motivated the 2023 legislature to commission these studies. Why have Minnesota's healthcare cost containment policies failed? If the studies commissioned by the 2023 legislature are done well, they will answer that question. The short answer to the question is because the legislature and Congress have been barking up the wrong tree. For 50 years, they have tried to contain costs by reducing quantity of medical services patients receive, when they should have been focusing on reducing the price at which these services were sold. If you're concerned about total spending in any sector of the economy, be it bananas or healthcare, you have to investigate two numbers: the price of the bananas and the quantity or volumes of bananas sold. Ditto for healthcare. The primary cause of healthcare costs in the US and Minnesota is excessive price. Excessive premiums, fees, charges, prices, not excessive quantity. But since the early 1970s, Congress and Minnesota legislature have focused almost exclusively on quantity because they were persuaded on the basis of no evidence that doctors were ordering services patients don't need, and HMOs would stop doing that through a combination of financial incentives to deny services and micromanagement of doctors. Those tactics, plus limitations on patients' choice of provider, doctor, and hospital, came to be called managed care by the 1980s. Here's an excerpt from an op-ed published in the Wall Street Journal in 2015. The author, Drew Altman, wrote, "Most of today's healthcare cost strategies aim to reduce the volume of tests, procedures, and hospital stays. Very few aim at the price of the health services. This is precisely what we should expect from 50 years of obsession with the quantity factor and near total neglect of the price factor. If I had just 10 seconds to answer the question, why has the US and Minnesota cost containment failed? I would quote those two sentences from Altman's op-ed. In this slide, we see that healthcare in the US became very expensive compared with other nations starting in the early 1980s. You see that US spending on healthcare as a percent of the gross domestic product, which is a measure of our national income. And it was similar to the other 10 other wealthy nations in 1980. But by 2019, we were spending 17% of our national income on healthcare compared to 12% for second place Germany and 11% for third place Switzerland. In this slide, you see that Minnesota was an average cost state in 1991, but we rapidly became a high cost state during the 1990s. By 2000, Minnesota's per capita healthcare costs were 10% above the national average. Why did healthcare costs begin to rise so much faster in the US than other countries in the 1980s? Why did Minnesota costs rise to 10% above the national average in the 1990s? We will review the evidence indicating that in both cases, administrative costs shot up and a consolidation accelerated. And both these problems, rising administrative costs and merger mania, were caused by the spread of HMOs and their managed care tactics. Just to give you a taste of how rapidly administrative costs shot up in the 1980s, take a look at this slide. The little yellow silver along the bottom represents physicians. The big blue-green mountain represents administrators. You see administrative costs accelerated in the 1980s and then exploded in the 1990s. Those were the years in which managed care was spreading thanks to the growth of HMOs and PPOs. Minnesota's costs rose in the 1990s because our prices rose, not because we suddenly started using more medical services than everyone else in the United States. Because Minnesota led the nation in promoting HMOs and managed care tactics starting in the early 1970s. Managed care spread earlier in Minnesota than it did in the rest of the country. Minnesota was also one of the first states to privatize Medicaid program. Because managed care spread throughout the Minnesota system earlier than it did the rest of the country, administrative costs rose earlier in Minnesota. And the explosion of mergers that eventually engulfed the entire country took place a year or two earlier in Minnesota.
We'd like to recognize the presenter for the second part of this video, Kip Sullivan, Juris Doctor. Kip is Minnesota's local health policy expert. Also recognized nationally for his expertise and substantial contributions to health policy literature, he has been organizing for universal health insurance since 1986 and for single-payer health care since 1989, and he has written extensively about our expensive and harmful health care system. He was an original member of the Board of Physicians for a national health program, PNHP Minnesota, and of Healthcare for All Minnesota, and now serves on Healthcare for All Minnesota's Legislative Policy Committee. We turn to Kip with gratitude for training all of us who are advocates for reforming our for-profit healthcare system into a single payer where we, the people, and patients come before profit.
Hello, everyone. I'm Kip Sullivan. I'm a member of Healthcare for All Minnesota's Legislative Policy Committee. In this presentation, I'll discuss the issues raised by any proposal to remove insurance companies from public insurance programs, including Medicare, Minnesota Care, and medical assistance. Medical assistance is Minnesota's name for its Medicaid program. I'll focus on Senate File 1059 and House File 255, a bill introduced in February 2025 in the Minnesota legislature. To avoid having to repeat both bill numbers over and over, I'll refer to the bill as Senate File 1059 because it was written by our chief Senate author, John Marty. Senate File 1059 would remove insurance companies from Minnesota's medical assistance and Minnesota Care programs. I want to begin with a warning. As of the date this video was recorded, the Trump administration and Congress are seriously considering substantial cuts to Medicaid. Medicaid is funded by the states and the federal government. A substantial cut in federal support for medical assistance will force our legislature to decide whether to cut many low-income Minnesotans off medical assistance, raise taxes, or both. Removing the insurance companies from medical assistance will cut the cost of insuring recipients currently enrolled in an insurance company by 10 to 15%. Depending on the size of the cut in federal Medicaid revenues, a 10 to 15% savings might be enough to ensure no enrollee has to be cut from the program if federal funding is reduced. In discussing health policy, we have to use a lot of jargon. I'll define a few of the jargon words on this list before we get started. I'll start with administrative costs. Expenditures by any insurer, be it an insurance company or a public program, consist of two categories. One, spending on medical goods and services, and two, spending on administrative costs. Administrative expenditures are any expenditures, including profit, that don't reimburse providers or suppliers for medical goods and services. Examples of administrative costs incurred by insurance companies include the cost of advertising, creating networks of doctors and hospitals, telling doctors how to practice medicine, and of course, profit. The phrase fee for service is self-explanatory. What you need to know about that phrase is it is often used as a synonym for public programs that don't funnel money through insurance companies, but instead pay providers directly. The unprivatized portions of Medicaid and Medicare are often simply called fee-for-service Medicaid or fee-for-service Medicare. Integrated Health Partnership is Minnesota's label for what the rest of the country calls accountable care organizations, or ACOs. The simplest explanation of ACOs and Integrated Health Partnerships, or IHPs, is they are HMOs on training wheels. I know you've all heard the phrase managed care. It refers to tools pioneered by HMOs. Those tools fall into three categories: exposing doctors to financial incentives to deny services, micromanaging doctors, and limiting patient choice of provider. Under the managed care label, you see the phrase managed care organization, or MCO. By the late 1990s, the distinction between HMOs and traditional insurance companies had become so blurred that insurance companies that used any managed care tactics, and by the late 90s that was all of them, were called MCOs, managed care organizations. Finally, you'll hear me say privatize and deprivatize throughout this talk. Privatize means turning a public function or activity over to the private sector. Minnesota's legislature privatized our medical assistance and Minnesota Care programs in the 1990s. In other words, the legislature turned those programs over to HMOs. Senate File 1059 deprivatizes medical assistance and Minnesota Care. In this and the next two slides, you see the most important provisions in Senate File 1059. Here you see the sections that instruct the Commissioner of Human Services, meaning the Department of Human Services, or DHS, to terminate DHS's contracts with MCOs, managed care organizations, and IHPs. This section tells DHS to pay primary care providers a monthly fee for coordinating care for medical assistants and Minnesota Care enrollees. You see that enrollees would have the freedom to choose their primary care doctor, something they don't have under today's privatized versions of medical assistance and Minnesota Care. Because Senate File 1059 restores patient freedom to choose their doctor and make decisions with their doctor about what services they need without interference from MCOs, the bill's authors refer to the program Senate File 1059 authorizes as the Patient-Centered Care, or PCC program. You can see the acronyms are piling up here. Finally, the bill authorizes DHS to fund community health workers to identify people who need help accessing medical care. This slide shows you why deprivatization will cut costs of all Minnesotans enrolled in Minnesota Care and medical assistance MCOs by 10 to 15%. Calculating the savings requires estimating three numbers, and you see them here on this slide: the administrative expenditures that MCOs incur, the cost of any increase in utilization of medical services caused by the removal of the MCOs, and any change in DHS's administrative costs. The big savings will come from the elimination of the MCO's administrative costs, which are approximately 15% of their expenditures. Those savings will be offset to some degree by increased utilization of medical services, because doctors who treat medical assistants and Minnesota Care enrollees will no longer have to get permission from MCOs to order services. Because MCOs make it very difficult for Medicaid agencies and analysts to determine what happens to the money MCOs get, we have very little information on the effect MCOs have on the utilization of medical services. I'll show you some slides in a minute that indicate Medicaid MCOs reduce services by the equivalent of somewhere between 0 and 5% of expenditures. The last item you see in the table in this slide is change in DHS overhead. We know DHS's overhead was 4 to 5% in 1990, before medical assistance was privatized. Healthcare for All Minnesota has asked DHS what their overhead is now and have not received an answer as of this date. If there is no change in DHS overhead due to deprivatization, then the savings from deprivatization will be somewhere between 10 and 15%. The next several slides present evidence documenting the numbers you see in this slide. I'll examine insurance company administrative costs first. Insurance company administrative costs or overhead eat up about 20% of every premium dollar they get from their private sector customers. This slide shows you a graphic prepared by America's Health Insurance Plans, AHIP, the Health Insurance Industry's trade group. You can see that AHIP says 21% of the premium dollar is spent on overhead, or what they call operating costs and net margin, aka profit. But when insurance companies are allowed to operate within Medicare or Medicaid, their administrative costs drop to about 15%. I have never seen research on this topic, but I'm pretty sure the reason for the reduced overhead is the insurance companies are no longer responsible for collecting revenues. After privatization, that's done by the government. This slide and the next three document the 15% figure. In this slide, you see two statements to the effect that Medicare Advantage plan overhead is 14% of their revenues. As I believe everybody knows, Medicare Advantage is the privatized portion of Medicare. Here you see a statement from the Lewin Group, a subsidiary of United Health Group, stating that Medicaid MCO overhead is 15%, and MCOs have to cut medical spending by at least 15% just to break even. But as we shall see in a moment, evidence indicates they cut utilization by somewhere between 0 and 5%, not 15%. This and the next slide quote data prepared by Milliman, a consulting firm. This slide quotes an article stating that Milliman advised New Hampshire's Medicaid agency that MCO administrative costs equal 12 to 15%. On this slide, you see the average percentage of expenditures on administrative costs for 186 Medicaid MCOs in multiple states, monitored by Milliman over the 2019 to 2023 period. The averages range between 11 and 15%. The estimates of MCO overhead costs we have just reviewed are probably a little low. That's because federal and state regulations permit MCOs to report as medical expenses the cost of so-called quality improvement activities. You see here a list of the criteria an MCO expenditure on quality must meet in order to qualify as a medical expenditure, not an administrative expenditure. It is highly unlikely that anything insurance companies do meet even a few of these criteria, much less all of them. If these so-called quality improvement activities equal even 2 to 3% of reported MCO spending, that would mean all estimates of MCO overhead in public programs are slightly low. We may conclude with confidence that 15% is a reasonable estimate of Medicaid MCO overhead. Now we turn to the second factor analysts must estimate to estimate savings from deprivatization, and that is MCO's impact on utilization of medical services. We have very little good research on how much MCOs reduce utilization by Medicaid recipients. This slide illustrates some of that research. It supports the estimate I showed you earlier that the reduction is somewhere between 0 and 5%. Now, how much of that 0 to 5% reduction is necessary care and how much is unnecessary care? Research on that question is almost non-existent, mainly because it is so difficult to determine how MCOs use their revenues. You see in this slide a rare example of an attempt by analysts to answer that question. Vilsa Kurtu and her colleagues made this statement about low and high value medical services in an article about the impact on utilization by Medicare beneficiaries. The authors call Medicare Advantage, the privatized portion of Medicare, a blunt instrument because it cuts out high value services as often as it cuts out low value services. A blunt instrument is an excellent metaphor for managed care in general. Several studies indicate MCOs are no better at reducing unnecessary services than non-MCO providers. There is, to sum up, no reason to think Medicaid MCOs are any better at distinguishing necessary from unnecessary care than non-MCO doctors, that is, doctors paid directly by DHS. Now we turn to the last of the three types of expenditures we need to estimate in order to calculate the savings from removing the MCOs, and that is change in DHS's overhead. This slide contains an excerpt from the final report of the Minnesota Healthcare Access Commission published in 1991, at which time the privatization of medical assistance had just begun. You see the commission stated that DHS's overhead was 4 to 5%. It would help to know what DHS's overhead is today. We have asked DHS for an answer, but at this date, they have not given us one. So at the moment, it's not possible to say whether there will be an increase or decrease in DHS's overhead after the MCOs are removed. The Minnesota legislature should have demanded evidence that inserting HMOs/MCOs into medical assistance and Minnesota Care would cut costs without harming patients before privatizing those programs. But the legislature has never done that. In 1973, there was no evidence supporting claims made for HMOs and the managed care tools they used. Nevertheless, the legislature enacted the Health Maintenance Act of 1973, authorizing HMOs in Minnesota. By 1982, when Minnesota asked the federal government for permission to force medical assistance recipients into HMOs in 3 counties, Hennepin, Dakota, and Itasca, there was still no evidence supporting the claim that insurance companies using managed care tactics could cut costs without harming patients. Nevertheless, the federal government gave Minnesota permission to force medical assistance recipients into HMOs in those 3 counties, but only on the condition that DHS conduct a rigorous comparison of the performance of the HMOs in the 3 privatized experimental counties with the performance of non-HMO direct payment doctors in adjacent counties. But the HMOs refused to cooperate, and DHS was never able to do the study. In the summer of 2004, several of us associated with the old Minnesota Universal Healthcare Coalition met with then House Minority Leader Representative Matt Intenza. We asked him if he would write DHS and ask them if they had any evidence indicating that privatizing medical assistance and Minnesota Care saved money. Kevin Goodnow, the DHS commissioner at the time, wrote back to say, quote, "There no longer remains a credible comparison group of fee-for-service recipients. We do not have a methodology that could accurately assess whether managed care has cost us more or less than fee-for-service." This slide indicates that as recently as 2019, DHS was unable to release data to analysts hired by CMS, the agency that runs Medicare, on how much MCOs pay doctors for taking care of Medicaid patients. The quote in this slide is from an article written by Regina Rutledge and other scholars hired by CMS to evaluate the performance of integrated health partnerships in Medicaid. You can see that DHS was unable, as the authors put it, to share accurate data on MCO expenditures with Rutledge and her colleagues. Fortunately, we do have some relevant research from other states. This slide contains excerpts from two papers, both of which found privatization of Medicaid increases costs. The first concluded that the privatization of California's Medicaid program raised costs and didn't improve quality. The second paper looked at Medicaid spending in multiple states and reached the same conclusion. Quote, the shift to Medicaid managed care increased Medicaid spending. Possibly the best evidence we have at this date is research on the deprivatization of Connecticut's Medicaid program. Connecticut privatized their Medicaid program in the 1990s and deprivatized it in 2012. A report released in December 2024 indicates deprivatization cut the cost of Connecticut's Medicaid program. You see in this slide a statement from Connecticut's Medicaid agency indicating the savings was in the neighborhood of 14%. 14% is consistent with the estimate I showed you earlier that deprivatization will reduce our medical assistance and Minnesota care spending on enrollees in MCOs by somewhere between 10 and 15%. Removing the MCOs from Connecticut's Medicaid program reduced costs and also improved quality of care for some patients. You see here a graph from a study published in 2024 indicating the rate at which doctors diagnosed cancer early rose after Connecticut deprivatized its Medicaid program compared with New Jersey's privatized Medicaid program. Again, deprivatization in Connecticut took place in 2012. This photo appeared in a slideshow prepared by Dr. John Kramer, one of the co-authors of the study on the rate of early cancer diagnoses in Connecticut after deprivatization. It shows a patient with a neck mass, as he called it, requiring a CAT scan, and following the scan, a referral to an oncologist. Dr. Kramer reported that the man's insurance company delayed the CAT scan for 2 weeks and then delayed approving the referral for another 3 weeks. Dr. Kramer noted, quote, disease progression, end of quote, probably occurred during the delay. Eliminating delays like this is probably the most important reason early diagnosis rates improved in Connecticut after deprivatization. We have very little research on the frequency with which Medicaid MCOs delay services. However, we have a few good studies on how often they deny services. You see in this slide a statement by the Office of the Inspector General of the U.S. Department of Health and Human Services that Medicaid MCOs deny 12.5% of all requests from doctors for prior authorization. This slide contains excerpts from two reports, the Connecticut report we've been discussing, and the Medicare Payment Advisory Commission's March 2023 report to Congress. I show them to you because these statements are typical of what experts say about the impact MCOs have on the quality of care. The typical assessment is that studies report, quote, mixed results. For 4 reasons, we should view that assessment as biased in favor of MCOs. First, studies that attempt to compare the quality of healthcare provided by MCOs with that delivered by non-MCO providers measure only a tiny fraction of the 10,000 medical services provided in the U.S. today. MCOs know in advance the short list of services they will be tested on, and that permits MCOs to teach to the test. Second, the impact of delayed and denied services is almost never measured. Third, some of the so-called quality measures are grossly inaccurate because they fail to take into account factors outside provider control. And fourth, studies usually fail to take account of the fact that MCOs are paid extra by Medicaid agencies to provide certain services that state legislatures do not allow fee-for-service Medicaid, that is, the unprivatized portion of Medicaid or unprivatized Medicaid programs, to provide. The next slide illustrates this fourth cause of bias in assessments of MCO quality. The slide will indicate that DHS pays MCOs for coordination services, even though the legislature has never allowed DHS to pay fee-for-service providers for those services. And here we go. This slide contains an excerpt from a letter to the Minnesota House Ways and Means Committee from the Minnesota Council of Health Plans, in which the council stated its opposition to two bills that would have deprivatized medical assistance and Minnesota Care. In this excerpt, the council stated DHS pays MCOs to, quote, provide coordination services, that the Minnesota legislature has never authorized the unprivatized portion of medical assistance to provide. There are two obvious errors in this statement. First, doctors and nurses coordinate care, not MCOs. Second, it makes no sense to say removing MCOs will rob medical assistance and Minnesota Care enrollees of coordination services when a simple and obvious solution is at hand. DHS should pay doctors directly to coordinate care, and DHS should stop paying MCOs to do that. That's precisely what Senate File 1059, our PCC bill, will do. Saving money without harming patients should be reason enough for legislators to support Senate File 1059. There is, however, one other important reason to support the bill. It will make a modest contribution to reducing physician burnout and possibly have a positive effect on the physician shortage we face now. This slide and two others address this issue. Here you see research published in 2024, which found very high rates of burnout, also called moral injury, among doctors caused by micromanagement by insurance companies. The study found that huge majorities of doctors, about 80%, say MCO demands for prior authorization interfere with patient care, and 2/3 say they contribute to burnout. This slide makes the same point with a different methodology. The authors asked doctors about their level of satisfaction with their state's Medicaid program before and after privatization. You can see that only a minority of doctors expressed satisfaction with Medicaid, probably because Medicaid's reimbursement levels are low, but that doctors were much more likely to say they preferred the Medicaid program prior to deprivatization. Minnesota and the nation are facing severe physician shortages in the near future. Our legislature should give high priority to reducing physician burnout. The legislature could make a modest contribution to reducing burnout and thereby the physician shortage by enacting the patient-centered care bill. As I mentioned at the outset, Senate File 1059 instructs DHS to terminate contracts with both MCOs and integrated health partnerships, aka ACOs. ACOs, accountable care organizations, resemble HMOs. ACOs are a more recent invention than HMOs, but research has already demonstrated ACOs don't cut costs and they don't improve quality. You see some of that research in this slide. The quote at the top of the slide is from an article I co-authored with Jim Kahn at UCSF. We reported that Medicare ACOs save no money and probably raised costs when their overhead costs are accounted for. The second and third quotes in the slide indicate Minnesota's IHPs are having no impact on cost or quality, and as the last quote indicates, if IHP startup and overhead costs are taken into account, they're probably raising costs. If that's the case, the savings Senate File 1059 will achieve will be even higher than the 10 to 15% we can expect from removing the MCOs. When Minnesota implemented our medical assistance program in 1966, it was a relatively simple program compared with today's Byzantine, mind-numbingly convoluted medical assistance and Minnesota Care programs. It was simple because DHS's predecessor, the Department of Public Welfare, paid doctors and hospitals directly. It did not funnel money through insurance companies or any other middleman. But in 1983, on the basis of no evidence, the legislature authorized DHS to privatize medical assistance county by county. And in 1996, the legislature privatized Minnesota Care. Then in 2010, again on the basis of no evidence, the legislature inserted integrated health partnerships into medical assistance and Minnesota Care. Since then, DH funds have had to filter through not one, but two layers of middlemen, IHPs and MCOs, before they reach the doctors and other healthcare professionals who actually treat patients. It is way past time for the legislature to undo its past mistakes and remove MCOs and IHPs from our public programs. Senate File 1059 will do that. Senate File 1059 will reduce costs, improve quality and access, and make it possible for the legislature to determine how medical assistance and Minnesota Care funds are used. Thank you very much for watching.
Thank you for watching this video. See the description below for links to the primary sources used during this training. Healthcare for All Minnesota has more videos and looks forward to you joining our efforts.